Okay, thank you everyone for joining us today. It's just about 5 minutes after the hour. We wanted to give everyone a chance to log in, but it looks like we've got a good amount of people here for the webinar today, so we will go ahead and get started. Welcome to today's webinar, which is a part of our Health Intersections Learning Community Group. Today's webinar is Case Management and Referrals to the Social Determinants of Health. And we wanted to start today with grounding our work in the promise of community action, as we do all of our webinars. So we'll recite the promise just to ground our work and the learning that we're doing today. Community action changes people's lives, embodies the spirit of hope, improves communities, and makes America a better place to live. We care about the entire community, and we are dedicated to helping people help themselves and each other. So this is our agenda for today's webinar. We're going to just do a quick overview of the learning community and give you guys some information about the work we do here. And then we will introduce you to today's speakers, and we'll hear from them about case management and referrals to address the social determinants of health. We'll engage in a brief question and answer session, so if you guys have any questions along the way, you have a chat box to the right of the presentation. If you make sure that you click send to all participants, and our hosts can see actually the questions that you ask and engage them. If not, I can be sure to voice your questions. There's also a Q&A question box on the bottom of the screen that you can write in more questions about if you're having any technical issues with the audio, and we'll be sure to address those. And then after that, we will go into our meeting schedule and wrap up and talk about some of the other upcoming webinars for the Health Intersections Learning Community Group. So we'll go ahead and get started. We said we wanted to start today by giving you a brief overview of the learning community to talk about why we're all here. The learning community, the real purpose of learning community is to build capacity of community action agencies to fight poverty in your communities, and we do that by working to connect you to effective, promising, and innovative practice models that alleviate causes and conditions of poverty, and really work to help you adapt and implement those models into your communities. And all of this work is grounded in the National Community Action Work Theory of Change. We're all working towards the same goals of improving outcomes for individuals and families, and ultimately for the communities that we work in, and making sure along the way that people with low incomes are engaged in that process. And so the learning community is really about the what. What are we doing to achieve those goals? What are the best strategies and services that we can offer to move the needle on those indicators, getting us towards those outcomes of improved lives, individuals and families, and ultimately communities. So that's really the work of the learning community, is focusing on that what. How are we going to do that? And in this round of the learning community, we're focusing on a number of strategies that we've identified that have proved effective to get us there. We've got 8 learning communities in this round. We've got Health Intersections, where we're meeting today, which is an open learning community group open to the entire network. In addition to that, the Decreasing Family Homelessness Learning Community Group, Results at the community level, Cultivating Data-Centered Organizations. We've got a number of intensive learning community groups, and also a few community practice. So we're engaging with the network on levels to help move forward and reach those outcomes. And here's just a brief snapshot of how all of those tie together to really build the framework for moving families and communities forward. And so here we have a quote from the Harvard Center on the Developing Child, and it's really about why we're taking this approach of learning communities, why we're not just disseminating this information about promising practices, but really engaging each other in this space so that we can ensure that we're learning together. So the quote I'll read briefly, learning communities provide a space and a structure for people to align around a shared goal. Effective communities are both aspirational and practical. They connect people, organizations, and systems that are eager to learn and work across boundaries, all the while holding members accountable to common data, metrics, and outcomes. These communities enable participants to share results and learn from each other, thereby improving their ability to achieve rapid yet significant progress. And put more simply, basically, small actions by lots of people equals big change is our goal. Big change is our goal. And just taking a look at what that looks like at the national level, we have those 8 learning community groups. They're engaging all 11 regions of the country, 33 states, and 407 counties. And ultimately, through this work, we have the power to impact over 1,640,000 individuals. So that's sort of a big picture look at the work that we're engaged in today. And here's a behind-the-scenes look at some of the people here that are working to pull it all together. As I said, my name is Liza Porras. I'm a program associate for the Training and Technical Assistance team here at the Community Action Partnership. I work under Jarl Crocker, who's the director of the Training and Technical Assistance team, and Courtney Kohler, who's our senior associate. The learning community is directed by Tiffany Marley, who I think is joining us here today, and she is supported by her program associate, Hyacinth McKinley, and also Charity Frankowski, who is a VISTA leader for the Rural Impact Project, which is also a learning community group. And then we also have Jeannie Chafin, the former OCS director, who is helping to support our community of practice for whole family approaches. So great team, really working to help you do the work that you're doing in the community. And without further ado, we'll get started on today's presentation. We are joined by Dr. Dana Long from UCSF Benoist Children's Hospital in Oakland, California, and her program associate. I don't want to mispronounce the name, so I will have her introduce herself. But she has helped us with a number of groups focused on health equity, and we are very honored to have her join us today. So without further ado, I will pass the ball over to Dana, and we will hear from her about referrals and approaches to connect people to health equity. All right, so Dana, we are ready for you.
Okay, and I'm here with Artenisa Jackson, who is the program manager for the Find Connect platform, which you will see a little bit of today. So this is actually the second webinar out of a series that I'm helping to lead. And my goal is that this webinar is very practical for all 36 of you on the phone. Today we're going to talk about resources, referrals, and case management around determinants of health. And as much as possible, I want this webinar to be helpful and interactive to those of you on the phone. And so as we're talking and posing questions, if you guys could please chat your questions and we can pause and address them. If there's something that you want us to focus on more, just let us know, and we can take a little bit more time. I honestly wish that I was in a room with all of you guys so that I could see you, but we'll do the best that we can from across the country. So we have 3 main objectives, and the first is to learn how social determinants of health can be incorporated into care coordination and workflows. Secondly, to talk about how we develop cooperative partnerships. And then third, to explore follow-up and case management methodologies. So what does all that really mean is that we're going to discuss the nuts and bolts of how to gather up community resources, how to do referrals, the case management, and then the follow-up. I want to share with you a little bit about what I do every day and where I work. So I'm currently based in the Bay Area in California at UCSF Benoist Children's Hospital in Oakland, and I'm helping to lead a regional effort called the Child Health Equity Institute. There's a link to a video that you guys can watch that really describes how we are aligning our work on advocacy, policy, research, and clinical transformation to all achieve health equity so that the Bay Area is the healthiest place for families and children. We want to achieve health equity for all. In particular, our clinical site is what we call a FQHC, a Federally Qualified Health Center. We've been in our community for over 100 years, and we're one of the largest pediatric providers in our region. Of the patients that we see, 98% of them qualify for Medicaid, and 90% of our families are also families of color. We have an extraordinarily vibrant clinic. It's a really busy place, and I'm really appreciative to all the patients and families that enable us to test out some of the work that you're going to see today, and to the families for sharing their wisdom with us. What I do know about our community, as is true for many of your communities, is that the children and families that live here have high levels of food insecurity. From our screening, we know baseline about 40% of our families are food insecure. And then when you ask families if they actually run out of food at the end of the month before they have money to buy more, about 21% will endorse yes, that they actually need food because they run out every month. Our families have an amazing amount of trauma. We have a big issue with housing in the Bay Area, and that includes not only just the lack of housing, but it also includes the habitability of the housing that currently exists. We know that within Oakland Public Schools, 65% of all incoming freshmen end up graduating from Oakland Public Schools, which is atrocious. And we're next to a port, and so there's a lot of environmental toxins, as well as a lot of community violence in our area. The goal of the programming that we developed is that how do we actually universally screen patients for unmet social and environmental needs, and then triage patients so that we can address the basic needs, such as the food, the need for activities, the need for diapers, for transportation to access nature, and then for families that need developmental mental health services, as well as families that have more complex needs, to then refer those up to our community partners. And we do all this using warm handoffs and culturally responsive care. We have a very extensive research and design aspect to our work, and it's really led us to be able to leverage technology for social impact so that we actually can screen families more effectively and do better follow-up and be able to aggregate and de-identify data on a regional population health level. We've piloted different models for who does this work. And what we found is that it's really important to involve the community in our leadership teams. So we have navigators, and navigators are essentially community health workers who can facilitate trusted relationships with not only the family, but the rest of the team that's interacting with the patient and the caregiver. Our navigators are super diverse and actually reflect the diversity of our community. Our navigators speak the languages of the community, being English, Spanish, Mandarin, Cantonese, and Arabic. By having community health workers work as part of a team, it enables the entire staff to work at the top of their license. And our navigators use technology as a capacity building tool to allow for screening, referral, case management, and follow-up. So during our last webinar, for those of you who attended it, we talked a lot about what are we screening for. And at Children's Hospital in Oakland, we universally screen for food insecurity, housing instability, access to transportation, diapers, the ability to pay utilities, substance abuse, issues of safety, and this includes making sure that there are car seats and bike helmets and cribs and safety locks, poison control numbers. We screen for development and then for both child and adult mental health. We talked a lot during the last webinar, which I know is on the website for the learning communities, about which questions to ask in regarding these topics. So for this webinar, we really want to focus on how do you gather these resources. And I'm actually going to pass the baton over to Artenisa Jackson in order to describe how we start to think about resources.
Good afternoon. Hi, everyone. My name is Artenisa Jackson, as Dr. Long mentioned, and I am the program manager for Find Connect, the program that Dr. Long manages and directs. And I'm going to start by talking to you all about how we have identified our resources and the process in which we use to populate our cloud-based system of resources. And so what we did, I'm a social worker by trade, and we went and asked folks like me, my, social workers, discharge planners, the folks who are, seeing the patients after their medical appointments, where are you keeping your resources? And, how would you like if there was a place where you could find all of these resources? Everyone responded pretty much the same, and folks had their resources on Post-its and in binders and in folders and in their head and Googling things. And when we presented the idea of having this cloud-based system, everyone was super ready to give us their resources. And so we took all of those resources. We got a bunch of the community health workers that Dana was mentioning, our navigators, volunteers, and they helped us to manually upload these resources into our cloud-based system. And we have an ongoing process of making sure that those resources are vetted properly and are up to date, and there are internal triggers that we have on our online platform that we use to help maintain those resources. The most important part of those resources is creating the warm handoff, and how we do that is before we even initially populate the resource, we're reaching out directly to these agencies, community agencies, and letting them know exactly who we are, and that we are referring our patients to them from Children's Hospital Oakland, and we want to, connect with them, and we want to understand their processes and identify someone specifically that we can, call by name and send our patients, our families directly to. And so that helps us to create the warm handoff. When our patients go to the community organizations, then these agencies already know who, who have sent them over there and why they are there. And so that is a really important part of our process. So what I was mentioning to you all is the cloud-based system that we have. We call it it's a knowledge base of resources, and it's a public-facing portal that anyone can access. You don't need to register or anything like that. However, we do stress the importance of having a relationship, that families having a relationship with the navigator. Although it is a public-facing portal, we want to support our families with that process so that they can navigate these different systems more effectively. We have language translation tools that is part of the process, and like Dr. Long mentioned, we have navigators that are that represent the clients and families that we serve, and so they speak several different languages, and our online tool also translates into those languages. We use a universal tagging system to identify and be able to sort through the resources that we adopted from 211's taxonomy coding system. And there are countless search capabilities where we utilize the platform and we can search specifically by location or by type of resource or by, eligibility things or different types of services that those organizations may provide. And there are also reporting functions that exist as part of our platform where we can pull data in real time, different demographic data that we collect from our patients. It's all de-identified, but we're able to, pull different data from different time frames and report on, the utilization of our platform, the enrollments of our families, what resources they're utilizing, and things like that. This is a sample of our knowledge base, just the home screen of the knowledge base. And I'm just going to read really quickly. At the heart of Find Connect is a vast collection of culturally relevant, geo-targeted resources that are referred programmatically based on the needs of the caregivers. And so this is just kind of what the home screen looks like. And as you see here at the top right corner of the home screen there, that's where you can search for the resources. And you're able to sort through these resources, again, based on the tags and different eligibility pieces of information that are connected to the resources.
Artemis, I just wanted to interrupt really quickly. We have a question from Carter Friend from your previous slide. She said, you mentioned 211. She said, how is your resource base similar and different from 211's? Did you consider using 211's?
That's a really good question, and we did consider using 211, and we actually did a pilot with that compared, two different interventions, and one intervention consisted of having, just providing resources to families from 211, and then the other intervention was not only providing those resources, but having the support of a navigator. And we ran into the same issue over and over again, where often 211's resources were not maintained appropriately, and information was incorrect, and families were getting connected to resources that, didn't exist or didn't provide the service that they were looking for. And so after we did that pilot, what we realized is that it is the relationship with the navigator that really helps to the families to navigate through the system and get those needs met and improve their health outcomes overall. And so it's more than just providing resources. It's more about the relationship and leveraging that relationship between the navigators and the families and the community agencies, so that families can get connected to the things that they need. So yes, we definitely considered it, and then we decided to go another route where, because we wanted to make sure that the resources were up to date and vetted, and that our families were going to places that existed and getting support that they needed. And could you imagine having to send a family somewhere, and you work this hard to build a relationship with a family, then we send them somewhere and it either does not provide what they need, and that there is damaging to that whole process, and really deter someone from being able or wanting to even go and seek out these resources after they've did who knows what to even get there. So yes, we definitely.
Thank you. That was a great answer.
Mm-hmm.
That makes sense. Thanks very much.
Thank you for slowing me down, and if there are any other questions, please stop me, because I'm not super familiar with this with the WebEx. And I did.
That was a great answer. Yeah, keep going. No, that makes sense with everything that you were talking about as well. So good question too.
Yes, great question. And so I was just going back and just kind of showing you guys what I was talking about as far as the knowledge base, our knowledge base of resources. This is our cloud-based system, and that's kind of what the home page looks like as far as resources. There's a program name, the organization name, and then the different tags that we attach to the different resources that allows us to search for those resources. And then on some of them, you'll see dates or expiring, and there's a column for expiring resources. And that is an internal cue for us to make sure that we are updating those resources accordingly. We're calling these agencies, making sure the person that we identified as a primary contact person is still working there. If there's a new person, we're updating that information, and we update the resources according to the type of resource that it is. And so for seasonal resources, we update them at the end of season. So it could either be, a summer or winter program or spring program that, and they expire after that. For local resources, we update those a little more frequently, every 6 months. And then for federally funded resources, we update those annually. And so that just helps us to make sure that our families are getting connected to resources that exist.
And can I ask another question?
Yes, please.
I see here in the image that it says the day that the resource was created. Is there also a thing that says when it was last updated as well? That sort of lets you know that.
Definitely. Sorry if you weren't finished. Were you finished with your question?
I finished.
So there's definitely, so in the back end of the knowledge base where when we enter the resource, there is space for us to put in a time frame for it to expire. And so it will populate the date that it exists, and that date may be different from the last time that it was updated. But like I mentioned, that there's a seasonal expiration date, a 6-month expiration date, and a federal expiration date. And so, depending on what type of resource that is, once we update it, we'll change the date to match the expiration timeline for that specific resource. And it doesn't show on the the front-facing screen to you, but on the back end where we update those resources, we're able to put those expiration dates in.
I see. Okay.
Okay. And I would just like to share this quote with you and how we define partnership when it as it relates to referrals, a relationship between individuals or groups that is characterized by mutual cooperation and responsibility is for the achievement of a specified goal. And so we get referrals a number of ways, and our primary referrals come through providers. Over 64% of our referrals come through providers. So we have self-referrals, we have social workers that provide referrals, the families can, I mentioned, can refer themselves, and navigators can recruit families and refer them in that way, and we sometimes have these kind of erroneous referrals that get to us in other ways. But so our navigators, when families come to their appointment and they're waiting to see their providers, our navigators can either go into the patient's room or in the waiting room where the patients are and let them know about the services that we provide to see if they're interested and they are enrolled in our platform.
Okay, we have another question actually coming in. A question about sort of overall records. When a referral is made, are those referrals recorded in the patient's medical record?
Yes. So we have the ability to refer through our emergency medical record system, which we call our electronic medical record system, which is called EPIC. And so providers can refer directly, like they can refer to any other specialty, like mental health or otherwise. They can refer to our program, our FIND program as well in the same way to support families with getting connected to different resources to support social and environmental needs. And so those referrals are maintained in the patient's record, and then we do collaborate and work closely with the providers as the relationship is ongoing with the families.
Okay. Thank you.
Then is there anything you want to add about referrals before I move on? Okay. And so this is an opportunity for us to have some interactive time. And I want to, if you could all take some time to list maybe 5 teams that you would need to meet with to facilitate this type of care coordination in your institution. And, you know, think about some of the obstacles that you might run into in trying to identify potential partners as you move toward providing these services to your families.
So as you guys are thinking, just make sure that you can enter those into the chat box so that we can let people know what people from across the country are sharing and let Dana and Artenesia know what people are sharing. So you can just enter your thoughts into the chat box so we can see those. Sorry, Dana. It's
okay. So as you guys think about who you need to coordinate with, I'm just going to share with you how Artenesia and I start to think about the kinds of teams that we need to be functional in order to address our family's social determinants of health. So as we answer this question, the types of partnerships that were really important to us are partnerships with the medical team, with our social workers and our therapists, with schools and other community-based agencies like food banks, with volunteers, and then super importantly, it's families and patients. So this is a picture of our navigators, and you can see that our navigators are super diverse and they speak the language of our patients, and we couldn't do this work without them. So let's talk about these teams one by one. So the first is the medical staff. How do you actually institutionalize the work on health equity within a busy medical center? And it comes from both the top and the bottom. It was really crucial for us to get buy-in from senior administration so that they understand that work around social determinants, it creates increased efficiency for the entire team. It allows everyone to work at their top of their license, and it actually boosts patient satisfaction. During one of our randomized controlled trials, we actually asked families, how satisfied with you are the services that you receive. And what we found out about is that our patient satisfaction was well above 97%. Among the physicians themselves, it's important to identify clinical champions who will really support other physicians in doing the referral to care coordination to address determinants of health. It's really important to figure out who else on the team needs to be involved in order to refer families, and in that case, it's often the nurse, whether it's an LVN or an MA, to cooperate with screening, and then to be really proactive or reactive in terms of what you screen for. And so my preference is that we always are proactive, that every single family that walks through your community agency gets screened for food insecurity, for housing instability, for development, and for mental health. But another way to do screening is if the provider ends up picking up that a family is hungry or homeless, that they then can refer once a problem is recognized. And so figuring out what works best for your team is also really important. One of the big concerns, and I'm really interested in you guys chatting about this, is how do we actually involve social workers and therapists, and what does this mean to their workflows? So some of the screenings that we do are for ACEs, which are adverse childhood experiences. And those of you that are part of this group might have heard of ACEs before, asking about issues of abuse, neglect, and household dysfunction. And when you ask these questions, how does that actually impact the work cues of the social worker? Is there going to be more mandated reporting? And there are so many fears about asking hard questions. And the truth of the matter is that what we found is that, one, families are amazingly gracious and appreciative and so thankful that the questions were asked. And two, we found out that it actually does not increase the workload of our social workers. It's important to have social workers as part of your team, but that has not increased the amount of CPS mandated reporting that's occurring in our clinic. We also have worked really hard with integrating into behavioral health services that are now becoming much more commonly part of the medical home. And so being able to meet with those integrated mental health service teams and to figure out how it is that community health workers, navigators, can do the initial screens. And in the last webinar we talked about, for us, those initial screens include screens like the PSQ2 and then followed by the 9, or screening for anxiety. So the PSQ2 is for depression. So how is it that we can actually have community health workers support the initial screening for depression or anxiety or substance abuse, and then be able to then give the warm handoff to the patient once they're screened for the mental health services team to then do further assessment? How do you actually create standardized work for each portion of the team so that we all can work together and are not stepping on each other's toes? And then how do we actually externally face and create direct referral pathways to our community partners? What does that referral look like? And so Artenesia had showed you guys a little bit of our knowledge base. And within each knowledge base item, we created an architecture. And so it includes the name of the person who accepts the referral, their phone number, their address, and then any forms that are really important for that community organization. Let me give you an example. We have a medical legal partnership, and for families that are being referred to the medical legal partnership, they have a referral form which we can download from our knowledge base. We sign it, the family signs it, and then we can fax it to that community-based agency. So being able to create those direct referrals is really essential. And then to figure out, be able to say, okay, well, this year we referred 50 families to our medical legal partnership. And to be able to track those referrals and follow up over time is super important for impact evaluations. It's always important to have new community partners that you onboard. So for instance, we're working more closely with our food banks on having the food bank themselves come to our clinic to deliver food, because we know that a large proportion of our families are food insecure. Or be able to refer to our local regional parks So we have an ever-expanding number of community partnerships. One of the partnerships that we're most excited about is working with our local school district in order to do screening for the incoming kindergartners and transitional kindergartners for this upcoming year. Health and education are so inextricably linked that being able to solidify the partnership with our local schools is hugely exciting for us. And we have a lot of volunteers who help us along the way. Those volunteers help not only do the screening, but they help us to maintain our knowledge base, and they help us to do a lot of our research efforts too, in terms of our data entry and then making follow-up calls. So Artenesia works very closely with our hospital volunteer department in order to onboard the volunteers and to be able to streamline that process as easily as possible. We are very clear with what our guidelines are, that volunteers have to show up. They have to be on time, they have to be respectful, and all of our volunteers have training on the principles and framework of cultural humility, which we really try to make the underpinning of all the work that we do. And the benefit to the volunteer is that they get fantastic experience, and we commit to writing them a letter of recommendation once they have at least 100 hours and they performed up to standard. We really do try to leverage the expertise of a lot of different facets. Most importantly is our family's experience. We just completed doing some work at the Stanford Design School on human-centered design. What is it that families need? What's most important to them? And what's their experience when working with us? This patient experience not only dictates how we design our technology, but how we actually incorporate the screenings into our workflow and how we work best with providers. Establishing these new partnerships, it's hard, and it takes a long time to go through all the bureaucracy. So when we first meet a community partner, like our local school district, it's actually taken quite a bit of time for us to all get on the same page, get the approvals that we needed, get contracts drafted and written up. And so make sure that you have a reasonable expectation for deployment and implementation when you first meet a community partner. And what we've learned over and over and over again is that showing up counts for a lot, to always make sure that we're there. And then part of a successful partnership is really recognizing what needs we have. And so for us, our need is to have a partner that speaks the language of our families, that is consistent, and that we can have a working relationship with, so that we can make sure that we have certain deliverables. One of our grants, for instance, we need to make sure that we are sort of counting the number of kids that go to a certain program. And so we need that program to close the loop with us when that family actually shows up. And so figuring out what everyone's needs are is really, really important. And ultimately, the benefits of partnership are really obvious, I think, to everybody on the phone. I'm going to skip over this slide because I think that the most important pieces about the follow-up and case management are coming. And so I want to pass it back to Artenesia.
Thank you. So I'm going to just go over briefly with you all just about our ongoing case management processes and follow-up and case assessment. Talk to you a little bit about how we do action planning and our team-based care approach. So just really, I'm going to go back. So just really quickly, we are navigators, and we have full-time FTEs, and we have volunteers that are navigators as well. And so we provide light case management to our families, where there's an expectation for the navigators to follow up with families every 2 weeks up to 6 months to see, you know, what's going on, have the families gotten connected to the resources that they need, and if not, why, if they need more resources, if there are forms or applications that need to be filled out, if there's resource or referral support that is needed. Our navigators are helping the families to do that. And we are documenting all of our follow-ups in our online platform. And what's really cool about our platform, and I know we haven't really talked much about the platform, but one of the really nice features of the platform is that the navigators receive emails from the platform to remind them when it's time to follow up with families. And there are, different permissions and settings where we can, where I, as a system administrator, I'm also getting those follow-up emails. And so if follow-up isn't happening, then I would know that, and I can nudge, navigators or volunteers to make sure that they're following up with their families. So once we do, we've created assessment tools and implemented surveys into our platform. And another thing that I really love about the platform is that it's really intuitive. And based on all the different tags and different things that we put into the back end of the platform, the system is able to make suggestions and derive resources for families based on their eligibility, geolocation, and language preferences. And so the screenshot that you see in front of you is a sample of an action plan. And the action plan, as you can see there, it lists the different types of resources that have been provided to this specific family. It will have the contact information for that family, for that resource. If there is, if everyone at the agency is supporting with the same services, there usually is not a contact for that that service. But if there is a specific person that our families can ask for, then we make sure we put that name down with that specific contact information and email address. If there are any PDFs related to the specific resource, they would also be listed right at the end under, at the last line of that resource. And so we're able to download this PDF and provide it to the families. We can print all the different resources individually. We can also print all the different PDFs. And there are PDFs that, maybe you only need one particular PDF. You can just print the ones that you need and give those to the family, et cetera. So I talked to you already about follow-up and case management, but it is also a part of the platform where we are able to create a running list of all the follow-ups, and this is kind of a screenshot of what it looks like inside of our platform. It lets you know, like, what navigator followed up with the family, what was the method of contact, was it by phone, face-to-face, or by email, was it contact with the navigator and the caregiver, or was it the navigator talking to the provider, or was it a navigator and a navigator communicating specifically about a family or, something that it needs to happen for this family. And then you can, state what the result was. Did you leave a message? Did you actually speak to someone live? And then there is a editable section for to write a brief note about what that follow-up was, and then the date of that contact is timestamped. And then so we get this running list of all of the follow-ups that we've had with our families. And so it's really important to track contact to see, who's been following up with the family, what's the status of the case, and it just allows us to conduct assessments on, what the needs of the families are.
Liza, I think there's another question from Barbara.
Sorry. There was. I missed it.
Yeah, so you moved on from this topic, so I was going to wait till we had the Q&A period. We do have we had a question about your navigators and how they're funded. Barbara had asked, are they paid for by the health center or the grant funds, or is there another funding source that supports the navigators?
So it's a great question, Barbara. Initially, when we started this work in 2012, it was part of the Center for Disease Control had these REACH grants, and REACH stands for Racial and Ethnic Approaches to Community Health. As you guys know, from 2012 to 2013, there was a sequestration of some of those federal funds, and so that funding was pulled, and we later got funding to join a research team at San Francisco General Hospital that was funded by John and Lisa Pritzker. Subsequently, we have had multiple different grant funds in order to fund those navigators. However, more recently, we've had two wonderful opportunities. The first is that we actually now have been contracted by our city in order to get essentially tax dollars, some measure funds, in order to support the workings of the navigators to support community health. And we are working with the administration within our federally qualified health center to operationally staff the desk as part of standardized care. We currently have 4 navigators who are helping with a variety of research studies plus clinical functions.
Awesome. And then just to follow up on that, we also had another question just about, it seems like, they're an essential component to making everything work, and finding the right people is important. When you are looking to hire navigators, what is the position description, and what is the experience that you are looking for in your navigators, the training, the education, when you're hiring your navigators?
So, and that's a really great question as well. So our navigators are essentially community health workers. We're looking for folks that come from the community that have, quote, been there, so to speak, that have an immense amount of compassion, and that also have the tech savviness to use our platform. We provide them with training on cultural humility as well as how to use the technology. And then they're paired with a team, and they do a lot of shadowing until they are sort of let go to do all their own screening, recruitment, case management, and follow-up. We also do a lot of recruitment of volunteers, and we use the same criteria for our volunteers as we use for our paid staff, so that they have to come in with an immense amount of empathy. We seek diversity in terms of language and experience as well as age.
Okay, great. And since we're going through questions, these were definitely more targeted towards the navigators, but back when we were talking about partnerships in general, there were a few questions and comments related to those partnerships. I think the one that's most relevant to this particular webinar was just a curiosity about your partnerships with your local CAPs. How strong is your relationship with your local community action agency, and what lessons can community action agencies learn from how to grow relationships with their health centers and in partnering together?
So the majority of our partners are community-based agencies. Our niche is addressing these unmet needs, these social determinants of health, and our very best partnerships are with our community itself. I think that for me, stepping out into a world that's often, healthcare is often very siloed, and being able to step outside of the silo of healthcare in some ways, and I don't mean to sound, I don't underestimate this, but it takes an immense amount of courage, I think, and willingness to say, okay, well, I don't know how this is going to go, but let's go ahead and try what this partnership is going to look like. And there's an understanding, I think, that, for instance, we're now partnering with a child care referral agency, with an understanding that kids can't show up and learn if they aren't healthy, if they're not fed, if their asthma is not under control, and if their housing is unstable, or if there's domestic violence, or if there's community violence. How do we actually all become more trauma-informed? And so there's a lot more understanding that health takes place in the community as opposed to in part of what has been considered health care. And so as we sort of nurture that understanding that health belongs to the community, it really has facilitated us all to work across silos. And part of it is figuring out how we actually can meet the community-based agencies where they're at. Artanisha, do you have any good examples of that?
No, I can't really off the top of my head
well,
at this point.
I wanted to share along those lines. We actually got a comment from somebody who's participating who mentioned a model that they have that sort of speaks to what you were saying. They have their family resource center located on the campus of a middle school, and they said they have a great working relationship, and that really stems from the mutual support that they have and knowing that their work sort of supports ultimately the outcomes of both of the school and the family resource center. But then that's really what moves this relationship forward, even though at any given moment it's not like there's particularly any results that the Family Resource Center is getting immediately from being at the school, but just having that shared support of the efforts really helps move the relationship forward. That was one example that was shared by a participant. I think that that's it as far as comments and questions. One more, actually. And what sort of databases are you using to track outcomes for social and community-based interventions?
What kind of database? So the database that we actually use is built into FindConnect. The reason why FindConnect was created was because there wasn't a database that we had that I knew of that existed in order to look at the process measures in terms of how families were screening, how families were being referred, and how we were doing bidirectional loop closing. And we also are using the platform for research, and so being able to combine the process measures for a clinical standard as well as a research project. I simply was unaware of something, and so we created our own tool. And I think that clinics or community-based agencies, you have to use what works for you. FindConnect is just one example, but there are several others, and if people are interested in learning more about it, I'm happy to have offline conversations with them about it. I did want to say one thing about the slide that's up, and this is the action plan. And I did want folks to note that within the action plan, there are two very specific things. One is there's a section for notes from the navigator, and then instructions for the family, because this is all about partnership. And so there needs to be space for the navigator to say, okay, this is what I'm going to do. I'm going to call you on Thursday. And then this is what the family's going to do, is that I'm going to sign up and I'm going to show up at that play group. And so we wanted to leave room for that partnership of trust to actually be documented. The other thing about the action plan at the very bottom is that each individual resource for each individual family has a unique SMX texting code so that the family can text our system back so that we can make sure the loop is closed for that resource. And that grew out of my need for us to know how are we following up and how good are we at resolving needs. Okay, Archnesia, I'm going to let you take it away now.
Okay, so just continue with the follow-up and case management portion. I just wanted to share this sample with you all of how you could track, the resources that you're providing to your family. So we're able to track this in with our online too, but this is just a sample. You can create something like this on your own, and it just creates a running list of the resources that you provided with your families and to your families. And when you call them back, you can just note the action taken, and it's just a way to keep track of the follow-up that you've had with your family, if you don't have access to a tool like Find. Another feature that we have is part of our warm handoffs. So we do, warm handoffs with our community agencies, but we also do warm handoffs internally for families depending on, what the needs of the families are. Sometimes families may get connected to a navigator who there may be a language barrier, or there may be some scheduling conflict or other thing that is happening. And so when that occurs in our platform, we've created the ability to kind of pass cases off to from one navigator to another navigator. And so we would select the receiving navigator, kind of check the reasons why we are handing off this case to another navigator, and then provide some verbiage around information that the navigator feels is important for this receiving navigator to know about the family. And then we initiate the handoff to this navigator, and that navigator becomes responsible for that family, and they're then responsible for following up with that family and providing the services necessary for that family. And this is our methods of follow-up that we currently use in our clinic, and we follow up by email, face-to-face, in person, by mail, phone, or text. And as you can see, almost 80% of our follow-up is by phone. We do follow up with families when they come in for their appointments, but we generally base our follow-up on, what the family's needs or desires are. So if a family prefers to be contacted through email, that is how we contact our families. If they, tell us that they'll be in the clinic next Friday and that's when they can follow up, then that's when we'll follow up with our families. So we want to have multiple methods of follow-up just because, sometimes phone or email is not an option for families depending on, their situations, but, it just allows us to make contact regardless of the situation. And so we define, Find Connect is redefined impossible by achieving health equity for all, improving population health, addressing preventative health upstream and at the root of the problem, changing healthcare from within the system, so shifting the paradigm of medicine and the way that medicine is currently practiced. And we're doing this through our team-based approach to care. We're leveraging the expertise of the folks that are supporting our families. So, the providers are doing what they're great at, the social workers are doing what they're great at, and the navigators are doing what they're great at. And in this effort, we're able to support the whole person, which is the families and clients that we're serving.
The goal of all of this work, as well as the Community Action Partnership, despite having significant adversity, we really want to create health-promoting environments so that all of our families and children can have healthy trajectories, and that programs like Find Connect or any other program that provides care coordination around social determinants of health, the goal is that we create these protective buffers for our children. So I'm happy to answer any and all questions or to go back to segments of the presentation. Thank you guys so much for listening.
Thank you.
Thank you. So I know that we were able to field a lot of questions throughout the presentation, and we are at the 3 o'clock hour now. But if there are any other questions, please enter them in the chat box, and we'll be happy to make sure that we present those. But in the meantime, since it is 3 o'clock, we'll just move forward with the webinar. And if we get questions along the way, I'll stop what I'm saying so that we can address Dana and Artemisha with those questions. So just moving forward, we will be posting the slides of today's presentation as well as the video of today's presentation on our Learning Community blog, and you can subscribe to follow other learning community resources here at www.lcrcweb.com. We also have resources at the CSBG TTA Center, which is www.csbgtta.org. So be sure to visit both of those to access resources connected to today's presentation and other helpful resources to support your agencies. And today is a part of our extended Webinar Wednesday series. There's going to be capacity building webinars every Wednesday throughout the spring and summer, and looking forward to help continue to provide information about promising anti-poverty practices. So you can always see our webinar schedule on our website here at communityactionpartnership.com and the webinar page. So always be sure to check to see what's upcoming. And speaking of upcoming webinars, we have a few other upcoming webinars in this particular learning community group. The next is April 25th, and then after that, May 23rd and June 27th. And the one coming up on April 25th is related to what Dana was talking about in the work that they do, cultural humility, people's principles and practices, providing a framework to expand one's approach with working with organizations and community members and help them better serve the clients that they serve. And we've got, this is a two-part series. The first is sort of laying the groundwork of people's principles and practices of cultural humility. And then on May 23rd, cultural humility as it relates to health equity. So that's a two-part series, really building on some of the work that we heard today. So be sure to register for both of those. We've got the registration links here in the slides, which we'll be sharing with you, and you can also go to our website to register as well. And then also, since we want to hear from you how your experience has been with this webinar and participating in the Health Intersections Learning Community Groups. We have a survey with just a short 6 questions just to make sure that we're meeting your needs and desires for health intersections. So if you go to this link, which also can be accessed from these slides and in a follow-up email, we'd love to hear from you how we're doing and how we can better meet your needs related to health intersections. And let's see, this is our contact information, so if there's anything that we haven't addressed or if you have any other questions, please feel free to contact any of us. And I'm going to see if we have any questions before ending out. I think that there's nothing more. So thanks so much for Dana and Artemisha. It was really, really helpful information, a lot that we can take from that. And thanks to everybody for your questions and comments today. So appreciate it.
Thank you.
Thank you.
Thank you. Have a good rest of your day.
You too.
Bye.